Almost done with microbiology, and I have to be honest, this has definitely been one of my least interesting. I do this channel because medicine is interesting to me. I do this channel because teaching is something that I enjoy, but microbiology is definitely one of my least favorite topics to really like stream, I suppose. I've only ever done all of microbiology once, and that was almost a year ago when I first started this channel up. I talked about all the bugs and everything, and I didn't have the book on the screen, and I would share the sketchy micro images and just discuss what's happening and how to memorize them and stuff. And at that point, it was exciting for a different reason. It was because it was the first time I was doing this on my channel, and it was like, I'm going to be growing. Maybe this is going to go well. Maybe it won't go well. And I was just there doing my thing. And now it's at a point where it's like, I'm doing microbiology for a second time. And I've done biochem like at least 4 times on this channel already. But doing microbiology a second time took a toll. This thing is so boring. It's literally just really, really basic and way too... I guess my interest in microbiology just isn't strong enough for it to be something that I truly enjoy. Like, I can't imagine... I don't think I've ever yawned so much in any other chapter of first aid than I have when I was doing microbiology. Like, I'm just glad it's done, and I'm glad I have the book there, and I'm glad it's completed now. Right? It's still not done, but at least this part now, like, we're done with the bugs and everything. Right now, it's like actually a little more clinically relevant with the systems and antimicrobials. But everything up to here, from basic bacteriology to the end of virology, was very disinteresting. And then I'm just glad it's done now. And we talked about a lot of stuff yesterday in the last video. We finished up HIV, which was definitely HIV and hepatitis were definitely part of the more interesting parts of microbiology, if anything, definitely more relevant. But it was still very hard just getting through it after having done all the gram positive and gram negative. And then I thought about it. I was like, a lot of these students that are watching my videos, a lot of the students that are starting step 1 prep right now, it's very important to make sure that you keep your mind busy with other things too, because it's so easy to burn out, right? Because I was actually burnt out. It wasn't just the microbiology and first aid that was burning me out, but I'm also tutoring multiple students, right? A lot of you saw the announcement I made where I was like thinking of taking new students on. So tutoring students, working on their materials, working on topics for my own channel, like I've been making NBME explanations, so I could have a video on that. And then, of course, just tutoring this stuff here to you guys on my live streams. It was all adding up. Like, I was doing medicine 100% of my free time. And then, when I wasn't free, I was probably doing medically related things as well, like going to the hospital or just interning or stuff. So, I went ahead and I realized, like, it's a priceless thing to treat yourself with things that are not medicinal. Do something that's of interest to you, another hobby of yours, something that makes you happy, something that gets your mind off of medicine, because it's going to burn you out, So, of course, yeah, I mean, everyone's seen I play League of Legends. That's always been there since the beginning of time. I play games to keep myself busy, but then the reason video games don't necessarily work too well is because I play it on the same laptop I do my streaming, the same laptop I study on, so it's like I'm still looking at the same screen per se. Yeah, so yesterday I treated myself. I went out with a couple of my close friends here. It was a nice fun night. Came back home and I felt a lot more relaxed. And I guess I'm just happy that we're finally done with all the gram positive and viruses and all that stuff. So that's pretty nice. Now we're looking at systems. So this is where the book finally starts helping you figure out, what bug or virus are you going to pick as your answer for any given presentation, right? And presentations include so many things, right? And that's how they break it down, right? So diarrhea, right? And then they have all the bugs that cause diarrhea and what you're supposed to see in your patient to pick a specific answer, right? Pneumonia, so many different things cause pneumonia, right? But then you can see it's divided by the population, and then of course there's other special groups, right? What else is in the patient's history? A lot of things are going to be given in the question to help you. Meningitis, and then osteomyelitis. Those are the 4 that are, Oh, and then of course this too. Yeah, urinary tract infections. 5 things so far, right? All the different various vaginal infections you can get. And then the last thing are your torches infections, right? After that, they go into different types of rashes and where you're supposed to identify them. Rashes are much more pediatric, if anything. Um, and that's gonna be pretty much all that we're doing, right? Then we go into antimicrobials. Okay, so it's really important to be able to catch what causes a specific issue in a specific population, age group, and history, and then you can go pick the correct bug. All right. So the first section right here, normal flora, right? Normal flora. So this is like stuff that's normally there. It's not going to be the answer for the most part, right? So like on your skin, you normally have S. epidermidis. The nose has S. aureus. That's a really big one, right? Colonized by S. aureus. Oropharynx has your viridins, and that is usually the answer for people who got dental procedures done, and they have like previously damaged heart valves, right? Oropharynx, viridins. Dental plaque, S. mutans, right? We've done practice questions on that too when we were looking at it. For the colon, Bacillus fragilis, much more than E. coli. And the normal flora of the vagina has a bunch of lactobacillus, right? Very important to remember that too, because when you lose the lactobacillus for any reason, maybe because of the antibiotics you were taking or something, then you can, predispose a patient to getting vaginal infections because they had been on antibiotics. Colonized by E. coli and group B strep. So bugs causing foodborne ileus, what are they? S. aureus and Bacillus cereus food poisoning starts quickly and ends quickly. And we saw that when we did these guys way in the beginning with gram-positive bugs, right? We saw the rapid onset food poisoning from both of these guys. Bacillus cereus is almost always going to be a question about something regarding reheated rice. Like this question stem has to have that, right? Food poisoning from reheated rice. Whereas S. aureus, which is the very first bug we did in microbiology, S. aureus was the woman on a horse, right? She's wearing a green robe around her, and not a horse, a camel, and on her camel she's carrying literally these things, the mayonnaise and meats, right? So if we do go back really quickly, just to, and these images are not easy to memorize without revisiting frequently, so you definitely want to make sure you connect the dots every time you do see any of these bugs, right? So this right here was the diarrhea portion of S. aureus, right? You can see she's got the mayonnaise, she's got a bunch of meat hanging there, she's on her camel, she's wearing green because that's for the vomit aspect of things, right? She's holding her mouth too, and the camel's running. So all that dust is running. The camel's running because it's rapid onset, right? And the same thing was there for Bacillus cereus as well. When we finally got to Bacillus cereus, right, it was mixed in with Bacillus anthracis right here, right? And this guy has rice in his hand that he just reheated, right? So he's vomiting. That's literally all that was. And little things like that, you got to remember it, because that's exactly what's going to give away the question. And it's going to be an easy question when it's those answer choices too. Other than that, C. botulinum. Now botulinum is very high yield when it comes to both of these things, right? Improperly canned food has toxins, and raw honey has spores. So the spores are what cause the issue in infants. So you never feed infants honey. And in adults, it'll be the toxins itself, not the spore, right? If adults ingest spore, they can actually get rid of it. They'll be okay. So that's why adults can eat honey. There's no issue with that. Right? We can eat all the honey we want, and we're not going to end up getting C. botulinum. But if there's some kind of improperly canned foods that have toxins in them already, there's no reason you're going to be able to deal with the toxins. You eat it, you end up getting infected, and botulinum ensues. C. perfringens. Now, perfringens, it's very rare to see this for a foodborne illness kind of thing to happen, but it can, right? We saw perfringens with the image in Sketchy Micro with the guy, the lieutenant guy on his motorcycle and how he fell, right? Because perfringens had a lot to do with motorcycle accidents. And there was soil all over the floor to remind you that it's just going to cause non-bloody diarrhea, and it's literally just from reheated meat. Reheated meat versus reheated rice, right? Two different things over here. And reheated meat versus undercooked meat is a big deal, right? E. coli you every time you think of E. coli, you definitely have to remember the sketchy microimage of E. coli where it's literally just a restaurant and there's a kid eating a burger, right? Undercooked meat. The meat was not cooked thoroughly. E. coli was in it. It didn't die. You ate it, and now you have E. coli infection. Right? Listeria monocytogenes for deli meats and soft cheeses. Right? Another thing that you're supposed to avoid in pregnancy. Right? Soft cheeses in the mother. Salmonella also is poultry, meat, and eggs related. Salmonella is a very common thing, especially with meat. So it happens where it happens. It's very rare in America, in the United States, but it can still happen in the United States as well, especially with all the food we import from other places. And then last thing is V. parahemolyticus and V. vulnificus. Right, this is just from contaminated seafood. Right, V. vulnificus can also cause wound infections from contact with contaminated water or shellfish. And this is a very rare one. This is not a high yield one at all, but again, remember when you do questions, if you have a bunch of answer choices you aren't sure about, definitely knock out the answer choices you know that are wrong. Once you knock out answer choices that are wrong, you have 2 answer choices left, most likely, and you pick the one that you don't know anything about, because the one you do know something about, you're not sure of. Right? If you know a little bit about one answer choice and know nothing about another answer choice, and the one answer choice you do know a little bit about doesn't seem to fit the question, pick the one you know nothing about, because it's probably the one that's going to fit better. It's a pretty safe bet to go with, and this is a technique you're supposed to practice when you're doing URL questions, right? And see if you were able to carry out that technique well enough. Now, continuing on with bugs causing diarrhea, the first breakdown between diarrhea is bloody diarrhea or non-bloody diarrhea, right? So bloody diarrhea versus watery diarrhea. The guys that cause bloody diarrhea are very invasive. They're going to be strong bugs. They're going to cause They're probably bugs you've already heard of a lot of times, either because you were in a city or state where something happened regarding one of these bugs, or you've just studied it enough. Alright, so Campylobacter, C. jejuni. Campylobacter was one of our comma-shaped or S-shaped organisms that grow at 42 degrees Celsius. This caused bloody diarrhea. Remember, in sketchy micro, bloody diarrhea was always depicted by a red stool. If someone was sitting or standing on a red stool, that's bloody diarrhea, right? Entamoeba histolytica causes bloody diarrhea. It was one of the protozoas we looked at. Enterohemorrhagic, EHEC or EHEC, right? EHEC. This is the one that causes bloody diarrhea using a Shiga-like toxin, and it was also related to hemolytic uremic syndrome, right? So you can get a kid who's coming back with hemolytic uremic syndrome, and he might have had diarrhea a week ago or 2 weeks ago. You know that's related to EHEC, right? Enteroinvasive E. coli, EIEC, just invades the colonic mucosa, so of course that also causes bloody diarrhea. Non-typhoidal salmonella, right? So lactose negative. Flagella motility has animal reservoir, especially poultry and eggs. Salmonella also causes bloody diarrhea. Salmonella and Shigella both do. Right? Shigella was the one that makes Shiga toxin, and enterohemorrhagic E. coli uses Shiga-like toxin. They're very similar in that aspect. And the last one, Yersinia, right? Yersinia enterocolitica also had a baby sitting there with the prairie rat on one side and a dog on another side in the sketchy microimage, and the baby was sitting on a red stool, right? So that's your daycare outbreaks, pseudoappendicitis, Yersinia enterocolitica. To remember the pseudoappendicitis, the prairie rat was actually licking the appendiceal end of the baby's abdomen, right? So the dog was just licking right there, and that was supposed to remind you of the pseudoappendicitis. For watery diarrhea, right now, the stool findings are a big deal, right? So right here in bloody diarrhea, stool findings are going to be fecal polymorphonuclear leukocytes with or without red blood cell. Salmonella will have fecal mononuclear leukocytes only. In watery diarrhea, stool findings will have no fecal white blood cells, no red blood cells either. It's just watery diarrhea. So watery diarrhea is different from bloody diarrhea in the sense that the whole mechanism is different, right? In bloody diarrhea, you're actually messing up the lining, you're destroying it. That's why there's blood, and then, of course, nothing's being reabsorbed, so that's why there's diarrhea. In watery diarrhea, you're just not reabsorbing anything. But there's rarely any invasion of the colonic mucosa or the intestinal mucosa. There's rarely any messing around with the actual intestinal system itself. The only thing that's messed up with is usually things like cyclic AMP and stuff like that, to really get the whole watery aspect of things not working well. And then there's no reabsorption. The patient gets dehydrated really quickly. Right? So you have your C. difficile and C. perfringens. They both cause watery diarrhea. C. difficile had this pseudomembranous colitis. Right? So these are things that the patient should be presenting with, basically, or some of this should be given in the patient's history. That would help you pick C. difficile as the answer for watery diarrhea. Right? Occasionally bloody diarrhea though with difficile, which it's a rare thing. It's usually just going to be watery diarrhea, but if it is bloody at all, it's not going to be crazy. It's not going to be a lot of bloody diarrhea like it will be with these guys above. Enterotoxigenic E. coli is a very rare question, but it's going to be related to someone who went to Mexico or somewhere in South America, right? So it's called traveler's diarrhea. Produces a heat labile LT and heat stable ST toxin, right? And you have to remember stable on the ground, right? So stable on the ground was for cyclic GMP, and what was the whole thing? It was labile and stable. I forget what the exact thing was. Stable on the ground, I always remember. So stable on the ground for the and labile somewhere. Let me see. Let's go back and check that out real quick, because that is definitely worth memorizing. Right, that image of why did I go to that? Oh yeah, mycology. Rickettsia. Okay, gram negative. Let's look at E. coli right here. So their thing was enterotoxigenic, interinvasive, similar. So heat labile toxin produces cyclic AMP, while heat stable produces cyclic GMP. And let me see. Right, so labile in the air and stable on the ground, I think it was something like that. Yeah, labile on the air, right? Labile on the air and stable on the ground. But I always remember the stable on the ground, which is definitely as long as you remember that, you're definitely going to be good to go. You'll catch what you need to catch. So stable on the ground, which makes sense because you're not in the air, so you're standing stable, right? Stable on the ground is to remind you of cyclic GMP, right? And labile in the air, this is the cyclic AMP. And you do get questions on that. You get questions on that comparison and the whole cyclic AMP part, because it's also cyclic AMP when you come to cholera, right? This also causes rice water diarrhea, and it's all because of cyclic AMP, which was actually depicted in the sketchy micro image where the guys had camp written on the map, right? So they can find where how to build the camps and stuff. So cyclic AMP, like you'll get microbiology questions where it's going to be like, what other bug causes the same issue as this bug in this question using the same mechanism, right? And then you have to answer that question with that manner. So V. cholera and E. coli, enterotoxigenic E. coli caused through the same mechanism, whereas enterohemorrhagic E. coli and Shigella caused pretty much by the same mechanism, and so on. All right, for viruses that cause diarrhea, we just talked about viruses, and it was always depicted by some kind of propeller in the image of sketchy micro, where the propeller was just throwing a bunch of brown water everywhere to depict diarrhea. So rotavirus, norovirus, and enteric adenovirus. Right, rotavirus was really fatal diarrhea for kids. For norovirus, you had the diarrhea with people who were on the ship, like Khaleesi. Khaleesi virus was one of them. Khaleesi virus is a norovirus. And then adenovirus had the K, right? It's one of the naked Statue of David was there. So it's one of the naked viruses, and it's a DNA virus. And it can cause diarrhea as well, but just watery diarrhea, not bloody diarrhea. So one thing to keep in mind is there are no viruses that will necessarily cause bloody diarrhea. So if you have a question about bloody diarrhea and a bunch of answer choices, and some of those answer choices are viruses, you can cancel those out. Right? Viruses don't necessarily ever really cause bloody diarrhea because viruses are not living things. They're not actual, they're not living bugs. So they don't actually invade anything like in any part of your body. They don't go ahead and destroy any part of your body. They're just bringing nucleic acids that are just going to cause issues because of the proteases and stuff they form. Proteins they form, I mean. All right, then the next thing is common causes of pneumonia, right? Very high yield topic. You're going to get a bunch of questions on your step 1, even NBME, where you have a patient that came in with pneumonia. And then you have to look at, how old is this patient? What does the patient do for a living? Is this related to pneumonia from some kind of job this person does, right? So like you're thinking at that point like asbestosis or something. You want to think of the history for this patient. Is he alcoholic? Does the patient have HIV? Is the patient getting diarrhea recurrent over and over, and so on, right? And then I listed out the number ones for everything. So for example, the number one cause of community-acquired pneumonia in adults is just S. pneumoniae, and that's a pretty obvious thing. S. pneumoniae is almost always there in community-acquired pneumonia. The number one cause of atypical pneumonia, and remember atypical pneumonias, there were a couple of them. There were specifically 3 that I kept repeating. But the number one cause of atypical pneumonia is mycoplasma pneumonia. The number one cause of pneumonia in alcoholics is going to be someone who pretty much just, they regurgitated aspiration pneumonia, right? They regurgitated their own saliva because they were knocked out unconscious from drinking too much, so they ended up getting Klebsiella pneumonia, right? That's the number one cause of pneumonia in alcoholics. The number one cause of pneumonia in a smoker is your second atypical pneumonia, Legionella. Legionella causes Legionnaire's disease, and that was also an atypical pneumonia from Legionella. The number one cause of nosocomial pneumonia was Pseudomonas. And remember, the whole setup had a nurse in there, so that was to remind you of nosocomial UTIs as well. And nosocomial pneumonia is also from Pseudomonas, number one cause. And these are all just notes coming from UWorld telling you the number one cause of stuff. Right, so they tell you here now in age group breakdown. So if you have a neonate, an extremely young neonate that just pretty much was born, and that neonate has pneumonia, then you immediately want to think of strep A galactiae, right? Strep A galactiae was the baby is being born to a mother who has strep A galactiae colonization in her vagina, and maybe for some reason this birth took place in a country where you don't do normal checkups of the vagina during pregnancy, during birth, right, in the last few weeks of pregnancy. And remember, in the last few weeks of pregnancy, you have to give the mother penicillin or ampicillin or some kind of penicillin, because that baby can be born with it, and then the baby will be born with not just the pneumonia but also sepsis and a bunch of other issues, right? And then E. coli. E. coli is here as well, affecting babies. Children that are up to 18 years old, right, so teenagers as well, usually get pneumonia because of, and then this is the list of things. RSV is going to be a very young child, right? Pretty much an infant. It's going to get pneumonia because of respiratory syncytial virus. Mycoplasma would be your atypical pneumonia that any teenager can have, right? Chlamydia trachomatis is going to be infection in newborns, so infants to 3 years old age, who pretty much got the trachomatis from the mother, while being born. C. pneumoniae is in school-aged children, right? So there's two different groups of C. pneumoniae, and then S. pneumoniae, right? This is just another one that causes pretty much everyone. We said that right here. S. pneumoniae is going to be in this row and this row. It's pretty much everywhere, right? You can see everywhere from here down to elderly. S. pneumoniae can cause pneumonia in anybody. So the way you cancel out S. pneumoniae as an answer choice is by looking at other things in the question. Does the question mention having low salt? Right? If there's salt wasting, then the answer is Legionella. Does the question give you an X-ray that just looks different from something that S. pneumoniae would do? Then it's not S. pneumoniae. That's how you cancel out S. pneumoniae. S. pneumoniae is just very basic pneumonia, straightforward. Nothing else is wrong. With mycoplasma, right? What happens in mycoplasma pneumonia? This is an atypical pneumonia in which the patient looks okay. They don't look like they have pneumonia. They just look like they have a cold. And then you do their chest X-ray and it looks terrible. And you're just like, wow, how are you still walking? Right? And then one of the other things that mycoplasma had was your cold agglutinins. Right? If you see the question is mentioning anything about IgM and cold agglutinins and stuff like that, you know the answer is mycoplasma pneumonia. Right? And then, of course, C, S, and viruses are there too. Influenza is one of the big deals that can cause pneumonia in a patient who hasn't gotten their flu vaccine as an adult. Right? And this answer choice for influenza is pretty much a thing that's possible everywhere. It can just keep going. Right? Influenza, viruses over here, again, influenza, and then influenza virus. So all adults can get it, even children. Right? Viruses is not just RSV. but this goes up to 18 years old, right? So even a 16, 15, 14-year-old could be coming with influenza pneumonia. Adults, you want to think of, as an adult from 40 to 65 years old of age, you really want to think of how immunocompetent they are, right? Is their immune system working, not working? And pretty much nothing unique here. All the answer choices are the same as they have been up to here, except the anaerobic stuff, right? And that really comes from, as an adult of this age, 40 to 65, so even 60 is included there, right? You want to think of whether or not this patient had a stroke, right? If the patient had a stroke, maybe their vocal or their pharyngeal muscles are not working too well, and they might have pneumonia from something anaerobic. The last thing are your elderly patients. For geriatrics, it's almost always S. pneumoniae for elderly. If it's not bacterial, then it's going to be influenza virus or H. influenzae even, but not really the most common thing. Not really the most common thing. And remember with H. influenzae, especially with kids getting it, right? Sketchy Micro had kids in it. Sketchy Micro had kids getting H. influenzae, and you had to give rifampin to all the close contacts. But adults can get it too. And the one thing about H. influenzae that makes it a little more unique than the others is the epiglottitis it causes, right? The epiglottitis it causes is different. None of the other guys really cause epiglottitis, so you want to see some kind of information in the question that explains this patient has epiglottitis. Then you can go ahead and just lock in H. influenzae, because S. pneumoniae or none of the viruses, mycoplasma, these guys don't really cause epiglottitis at all. Right, so very important to learn that differential between all of them. For the same thing with pneumonia, special groups, right? So now you're going to be looking at the patient's history, not just the age. So thanks for your help. Yeah, no problem. I mean, at the pace I'm going on lately, it's been pretty slow, but only because I don't really like microbiology. Tomorrow I'm going to go into pathology, and I should be done with all of pathology in 3 days, right? Because I just want to spend a whole day on each one of these topics. But, first aid is huge, and there's so much to cover. So I would say that by the end of next month, I should have all of this covered. And as far as order is concerned, that really depends on where you're at when you're studying, right? So if you're already done with everything and you're taking step 1 pretty soon, pick the playlist that helps you and go watch it, right? Because I already have playlists for all the systems already. I've already done videos on hematology, musculoskeletal, everything. So if you need help with, for example, maybe you need help with renal, those videos are already up there. It's just now, renal is a lot better in my book, so I'm redoing the whole book. Not just as a way to help, but also as a way to show people the book, so that if anyone's interested in buying it, they can email me. Right, so if you want, you can continue watching along on this playlist with the full FA playlist, or you can just go pick a playlist that you need help with for whatever topic, respiratory, renal, etc., and watch that. But yes, thank you for your feedback. I appreciate that. So after looking at the age of a patient and their presentation, you want to look at their history, right? For any patient, any question. As far as pneumonia is concerned, the history tells you a lot and really helps you point out a specific diagnosis. Alcoholic being one of the best and easiest ones, right? Klebsiella is going to be an alcoholic patient in the hospital who then developed pneumonia in the hospital. If they had pneumonia when they got to the hospital as an alcoholic patient, then it's probably an aspiration pneumonia, at which point you pick one of these answer choices. Any one of these anaerobic answer choices. Peptostreptococcus, Fusobacterium, Prevotella, Bacteroides, right, like Bacteroides fragilis or something. And the reason you pick one of these guys is because there's a difference between when you get the pneumonia. That makes a big difference. If you came to the hospital with pneumonia as an alcoholic patient, so maybe this was an alcoholic patient that was found unconscious somewhere and they have pneumonia now, that's probably aspiration pneumonia, so you pick one of the highlighted answer choices right here. If this is an alcoholic patient who now is in the hospital, not due to pneumonia, but just because they needed help with something, maybe they had thiamine deficiency, and then in the hospital they end up developing Klebsiella pneumonia, that's what you pick, right? It's developing pneumonia, then it's Klebsiella, because Klebsiella is pretty nosocomial. It's very resistant to many antibiotics, and it's a really hard one to deal with. IV drug users is almost always going to be S. pneumoniae as the answer. You pick S. pneumoniae as the answer unless they gave you something specific to help pinpoint S. aureus, right? If they didn't give you a characteristic of S. aureus, if they didn't give you any other reasoning to pick S. aureus, then lock in S. pneumoniae as the answer for that IV drug user. Aspiration pneumonia, we just said it right here, right? So the Pepto, Streptococcus, Fusobacterium and stuff. And that's actually significant because the reason they're different is because, yes, sure, alcoholics can have aspiration pneumonia, but aspiration pneumonia itself can be a thing for many other patients as well. Like I said earlier, a patient who might have had a stroke, right? And now their pharyngeal muscles are not working so well. So that's one example of someone who can have aspiration pneumonia. Also someone that's just, constantly maybe having seizures, right? Really, really bad tonic-clonic seizures, they can have aspiration pneumonia because during the seizure they might have just swallowed a bunch of stuff that they shouldn't have, or not swallowed, but actually taken it into their lungs, and they shouldn't have, right? So that's the seizure one. So there's other ways of getting aspiration pneumonia other than being an alcoholic. Cystic fibrosis, these patients are going to be coming back with recurrent pneumonia, and there's a couple answer choices, but Pseudomonas is the number one cause of pneumonia in cystic fibrosis patients, right? So that's what you want to pick, unless they gave you a reason to pick aureus or pneumonia or Burkholderia even, right? If there are things given in the question stem that don't really match up with Pseudomonas, and it's not matching S. aureus or pneumonia either, then just pick Burkholderia and call it a day, right? Otherwise, you should feel pretty confident in just locking in Pseudomonas simply because the patient has cystic fibrosis, unless they gave you things to help you pick S. aureus as an answer choice or S. pneumoniae as an answer choice, right? So they'll probably give you like details on the bacteria, catalase positive, coagulase positive, etc. You pick S. aureus, or they might give you a histological image that can help you determine which bug is causing the pneumonia. So at that point, it's a picture of the answer. It's a giveaway, right? Unless you forgot how the bug looks. In immunocompromised patients, the answer is almost always going to be S. aureus, unless it's an HIV patient, right? There's a difference between being immunocompromised and being an HIV patient. Immunocompromised people could be someone who has been taking medications to suppress their immune system because of a transplant they got, or maybe because they've been just really, really sick lately, right? So stuff like that, that's going to be S. aureus. But otherwise, if it's an HIV patient, at which point maybe the question is going to tell you their CD4 count is like 180 or something, under 200, then you pick Pneumocystis jirovecii as the answer. And the question might even give you an image, a histological slide of silver stain, right? And you could see the methylamine silver stain, the little circular bacteria that Pneumocystis jirovecii is. And I think we can go ahead and just really quickly find that too, because that's actually a pretty high yield picture that they love throwing at people. Pneumocystis, where was it? Where was Pneumocystis discussed? It's right here. I passed it real quick. Okay. Right, so Pneumocystis jirovecii, again, you're going to see like this, right? They're going to give you the, where is it? Silver. Yeah, methylamine silver stain of lung tissue, right? And they might not even mention the methylamine silver stain. They might just give you this image and be like, this is what we saw when we looked at whatever came out of the lungs under the microscope. And you can see how they look, right? They describe it as a disc-shaped yeast, right? It's not one of your it's not one of the bacteria. It's under the mycology section, right? So this is the stuff that causes pneumonia in HIV patients, and this is how they're going to present it to you, right? Here's another picture of the same thing at a much lower magnification, right? So you know that this has to be pneumocystis just because of the color of the image and the little black dots you're seeing. Otherwise, you can't really even see the bugs very clearly here. But you just got to pick it because that's what seems like the best answer choice for a patient if it's an HIV patient. Nosocomial or hospital-acquired, right? So nosocomial, usually Klebsiella, but also Pseudomonas. And I put here, number one cause of nosocomial pneumonia, Pseudomonas, right? So you just lock in Pseudomonas unless they give you a very specific reason to pick S. aureus or Klebsiella as an answer choice. Klebsiella also causes nosocomial pneumonia, so be careful in picking one over the other. The only difference is Klebsiella causes nosocomial pneumonia in alcoholic patients. Post-viral, now these are super infections that really make things much worse, right? So post-viral pneumonia is usually actually going to be H. influenzae, right? But you really have to just pick an answer based off of what they tell you in the question. So it's really going to be based off of either a histological slide they gave you, some kind of detail they gave you about the bacteria, or some kind of detail they gave you about the symptoms that these bacteria cause. Otherwise, there's no easy way per se. Now, meningitis, just like we talked about pneumonia, meningitis has a very specific breakdown as well in terms of age group. When did you get the meningitis, right? And the history, what kind of history the patient has. So age group wise, we've talked about pretty much all of these already. We've done it, right? So newborns who are born with meningitis, there's two that are really high yield, right? It could be strep A. galactiae, at which point you would only pick strep A. galactiae if the mother was not regularly being checked, right? Otherwise, in America, it's routine to check the vaginal flora weeks before the delivery is about to happen, and then start ampicillin or penicillin in the mother right before delivery, because otherwise the baby's going to get it. And Listeria meningitis, again, Listeria can cause meningitis as well. Sorry, not Listeria meningitis, but Listeria meningitis can occur as well. Oh God, this guy's back again? Wow. He was gone for quite a while too. Now he's back with his bullshit. Anyway, yeah, Listeria would be, you would either get details about the bug itself, like the rocket jumping that it does, or they would, and again, Listeria is also treated with ampicillin, but they would have to give you some kind of detail, like maybe the mother had cheese or something, cold cheeses. They would have to give you something for you to pick Listeria, but also just remember that it cannot be strep A. galactiae in a mother who was routinely checked during the pregnancy and, perinatally, because then she would have been taken care of while she was at the hospital. E. coli is the only one that, can be the answer if both of those guys don't fall into place. If the mother wasn't doing anything that would get her Listeria, and the mother was regularly checked so she can't have strep A. galactiae, then you just pick E. coli. For whatever the reason is, she got E. coli somewhere. Children up to age 6, right, so from newborn to age 6, the most high yield answer here for meningitis in these patients is going to be S. pneumoniae, right? It's not going to be any of the other guys. It's very rare for it to be any of these other answer choices. S. pneumoniae, I would say, is number 1. Number 2 is a tie between H. influenza type B and enteroviruses, right? Enteroviruses that we talked about were all of your picornaviruses, the echovirus, Coxsackie B, right? Those were all enteroviruses that can cause meningitis in kids, right? So again, they would have to give you more details on the bug itself for you to be able to pick it at this age. Between 6 to 60, this encompasses teens, right? And you can see number 1 in teens is Neisseria meningitidis. Neisseria meningitidis in college students, high school students, and you have to again give rifampin. You have to give rifampin to all close contacts at this point as well. And after that, of course, S. pneumoniae and enteroviruses are all there too. HSV for meningitis, it's rare. I don't see a question coming to you about HSV causing meningitis. HSV1 is the number 1 cause of sporadic encephalitis, and HSV2 is more so related to genital herpes, right? So it's not going to be the number 1 thing. It's not a very high yield topic, but if they give you reason to pick HSV, then you do it. And then, of course, elderly, right? 60 plus, really, really old patients. Remember, Listeria had the Santa Claus guy in it. That's the elderly patient. And also remember, when you treat meningitis, you always have to add ampicillin if Listeria is suspected, right? So give ceftriaxone and vancomycin empirically to any patient that comes in with meningitis. Before you even start checking what's causing the meningitis, you have to treat it. You can't let it get worse. You can't let it get problematic. What an asshole, man. Like, this guy. I hate this guy. So, one of the things that suck in America, it's a good thing and a bad thing, but one of the things that suck in America is you can't do anything to anybody, right? I can't do anything to him. He has the right to go burn his house if he wanted to, for that matter. Or at least that's how it feels. As long as he's not directly harming me, which I can arguably say he is, but I can't do anything until he's like maybe punching me or something. So yeah, any patient that comes in with meningitis, you give them ceftriaxone, you give them vancomycin, and you add Listeria if you think it's a possible thing. If it's a scenario where there's no way it's Listeria, then you don't give Listeria. But generally speaking, most places you will give all three medications, because why risk it, right? Just give the ampicillin. Maybe it's Listeria, maybe it has something to do with an AC or cold cheeses or something, and you just go ahead and treat everything. Viral causes of meningitis, like enteroviruses, especially Coxsackie, HSV2, right? They're saying HSV2, and then HIV, West Nile virus. Now, West Nile virus was really big. West Nile virus was a problematic bug for many reasons. And then varicella zoster virus, right? So I've never really seen questions that were high yield regarding just these guys, but it can happen, I guess. And in HIV patients, just remember Cryptococcus, right? Cryptococcus causes meningitis in HIV patients, and we did HIV yesterday. We talked about the specific things that occur in HIV patients because of their CD4 count. Cryptococcus usually, if they don't give you details to be able to pick Cryptococcus as an answer choice, but nothing else is fitting of all the bugs that are in the answer choices, you just pick Cryptococcus. If it is an HIV patient and there's no specific details for you to be able to pick a specific bug as an answer choice, you just pick Cryptococcus. Then the last thing they tell you here, note, incidence of H. influenzae meningitis has decreased greatly due to the conjugate H. influenzae vaccinations. Today, cases are usually seen in unimmunized children, right? Children that do not have the immunization. CSF fluid findings in meningitis. Now, this was discussed when we did picornavirus, and we talked about the enteric picornaviruses. It's really, this table is great to, teach it to you in the beginning and for you to understand it at first. But, I'm starting to get sweaty now because I'm getting real mad at the guy next door. But it's pretty much straightforward, common sense stuff, right? It's not really that bad. So what are the 4 things you're looking for in CSF? You're looking at the opening pressure, the type of cells that are predominantly in the CSF, is protein count normal, and is glucose count normal. Now you could imagine, with bacteria, right? If you have a bacterial cause of meningitis, glucose is going to be low because the bacteria eats it all. Just think of it like that, and that is what's happening. So glucose is going to be low, right? You're going to have a lot of PMNs because neutrophils are going to be there to fight the bacteria. And protein is going to be slightly elevated, not so much. It'll be slightly elevated, not because of the bacteria directly, but some of the things the bacteria might have brought with it, and then the neutrophils itself. But the most significant thing about bacterial infection for meningitis in CSF is the low glucose, right? Fungal and TB meningitis also has low glucose for the same reason. They ate the glucose. Now, the main difference between bacterial and fungal is right here. Right? For bacterial infections, you're going to have neutrophils. For fungal and TB, you're going to have lymphocytes. Right? So what's higher in the CSF is really going to help you determine what's the answer. When you come to viral, so you can see viruses, they're not living things. So the viral glucose is just going to be normal. Right? They're not eating the glucose, nor are they making more glucose. So in the CSF, your glucose values are just going to be normal. Protein should be elevated, not normal. It should be elevated because viruses have nucleic acids, and that is all amino acid, it's protein. And again, lymphocytes, right? Because it's a virus. But the opening pressure for viral meningitis is almost always normal. There's no increased opening pressure. I don't really know why the opening pressure goes up with bacterial and fungal infections, but it's just something you have to remember. The opening pressure is just higher. I think of it as there's just much more volume to the CSF, so the opening pressure is higher, but I'm not 100% sure what causes it. Now, the next thing is infections causing brain abscess, right? So brain abscesses. And we've seen many different kinds of brain abscesses. Yesterday, when we talked about HIV and AIDS, we talked about toxoplasma, right? Toxoplasma gondii reactivation in AIDS. So infections causing brain abscesses, most commonly viridin, streptococci, and staphylococcus aureus. These are the most common infections that can cause a brain abscess. If dental infection or extraction precedes the abscess, oral anaerobes commonly involved, like the viridins guys. Multiple abscesses are usually from bacteremia, right? So that's something you're thinking of when you see the MRI or whatever. If there are multiple abscesses, it's a bacteria. If it's a single lesion from contiguous sites, right, otitis media and mastoiditis, then you want to think of the temporal lobe and cerebellum, sinusitis, dental infection, frontal lobe, right? They're giving you the different breakdowns, right? So with bacteremia, you're going to have single lesions from contiguous sites, which is why you have multiple abscesses, right? So single lesions throughout the different body, different parts of the brain. Why is it single lesions from contiguous sites? It's just because that's how bacteria work, right? They're just going to go all over, they're traveling in your blood, and then they're causing abscesses in different parts of the brain. Now, if it's a patient who had otitis media and mastoiditis, then you want to think of the temporal lobe and the cerebellum, right? Because the ear is closer to those sections. Sinusitis or a dental infection, a patient had a sinusitis or dental infection and now they have multiple brain abscesses, then you're looking at brain abscesses in the frontal lobe, right? And because of what they had before the brain abscess, that history is what's going to help you pick what bug might have caused it. Right? So that's what they're kind of trying to get at. But toxoplasma is always going to be the really easy answer choice to pick for an AIDS patient, and you're going to see multiple ring-enhancing lesions for toxoplasma. Osteomyelitis is pretty easy. The only thing that's difficult about osteomyelitis is realizing that a patient has osteomyelitis and not like bone cancer or something. Right? Osteomyelitis is basically inflammation of the bone. So now, risk factors. Of course, before anything, the number one cause of osteomyelitis is Staph aureus. If we go back to Staph aureus again, because it's the easiest picture to go back to, it's the first one. Remember what the sign for osteomyelitis is? It's always going to be fish bones, right? You're going to see fish bones somewhere, and it fit perfectly here because it's all dried up, right? It's a desert, so the water is all dried up and gone, so the fish have all died and you have fish bones. So fish bones are always going to be there in a picture that has osteomyelitis involved with it. Here, Staph aureus is the number one cause of osteomyelitis. Number one, most common overall. Assume it's Staph aureus if no other information is available for you to pick a different answer choice. Now, what else can cause? What other different answer choice can be there in the question so that you don't pick S. aureus? Well, if the patient is sexually active and maybe they had chlamydia or gonorrhea earlier, then septic arthritis, right? Septic arthritis is usually going to be the follow-up in that patient. Septic arthritis is more common from Neisseria gonorrhea than osteomyelitis is, but it can lead to osteomyelitis as well. Sickle cell, the giveaway, right? If a patient has sickle cell, they're extremely prone to they're pretty much not going to have a spleen, right? They're going to be asplenic. So because of that, they're really prone to encapsulated organisms, and salmonella is the answer you pick for sickle cell patients. Any sickle cell patient, osteomyelitis, salmonella is the reason it's happening. Prosthetic joint replacement. So someone has like a fake knee or a fake valve, right? And now they have osteomyelitis. Chances are the answer actually is S. aureus, but if the question is really pointing at things that are supposed to make you think it's S. epidermidis, just pick it. Maybe they give you some qualities of the bacteria, catalase negative, etc., urease positive, whatever. Then you go pick S. epidermidis. Vertebral involvement. Now, every time it's vertebral involvement, the answer is always S. aureus, unless this is a patient who had tuberculosis. If the patient had TB, then now the reason they have osteomyelitis is not S. aureus, but it's actually pot disease, and they have the osteomyelitis because of TB, right? It's not a different infection. Cat and dog bites are always a giveaway for Pasteurella, right? We talked about Pasteur. In that image of Louis Pasteur in his lab, he's getting bit by a dog, and there's a cat on the side for catalase positive, but the main thing was he's holding up fish bones, and that's why the dog bit him. Right, so he's holding up fish bones for osteomyelitis. A patient that got bit by a cat or dog sometime last week can now present with osteomyelitis because they didn't get treated for the Pasteurella multicida infection. IV drug use leading to osteomyelitis is almost always S. aureus, unless the question gives you reason for you to pick Pseudomonas. Pseudomonas had multiple things on that image. besides the fake Mona Lisa in her tub, there was a table there, right? The table had a jar of candy for diabetic patients, right? If it's a diabetic patient with IV drug abuse and now they have osteomyelitis, you can pretty much safely pick Pseudomonas. There were also fish bones there for the osteomyelitis on the same table. And it's very important. I've never seen Candida causing osteomyelitis, so I don't even know why they mentioned this here, but whatever. IV drug abuse can apparently cause Candida-induced osteomyelitis. And things you see in osteomyelitis, well, of course, it's inflammation of the bone. So the x-ray might try to confuse you into thinking like it's osteosarcoma or something, but it's not. And the way you'll be able to differentiate it is basically they're going to have elevated things of inflammation, right? ESR, erythrocyte sedimentation rate, how quickly the blood cells are sticking to each other, and then CRP, right, C-reactive protein. If these things are elevated, you know it's inflammation. Radiographs are insensitive, right, because you can't really tell if it's osteomyelitis or a bone cancer. They're insensitive early, but can be useful in chronic osteomyelitis, which is obvious because no one's going to keep getting bone cancer and healing and then getting bone cancer and healing, so it's not bone cancer anymore. Is probably osteomyelitis in a chronic fashion. MRI is best for detecting acute infection and detailing anatomic involvement. Right, so that's what you're kind of seeing here. Right, so MRI is the image of choice for a patient with osteomyelitis. Now there was a question up here I didn't do. Let's check it out real quick. So this one. Right, so the UWorld had a question. 22-year-old male presents to the ER complaining of fever, abdominal pain, and vomiting. Right, so 22-year-old, fever, abdominal pain, and vomiting. He has had these symptoms for 4 days, and he appears acutely ill. There is right quadrant tenderness with rebound. Rebound tenderness. All right. CT of the abdomen and pelvis demonstrates periappendiceal fluid collection. Culture of this fluid would most likely isolate which of the following bugs? And the answer was Bacteroides fragilis, right? Because the colon. Right, B. fragilis was the answer. The reason I put this here is because this question itself was a perfect display of how knowing the normal flora was really important. Right, Bacteroides fragilis is a common anaerobic gram-negative bacillus that is frequently isolated in perforated appendicitis. This organism expresses unique surface polysaccharides that favor abscess formation, and that's what happened to this 22-year-old. Right, he had appendicitis. That's why he had the pain he had in the way he had, and that's it. Right, so no other bug in this question was actually fitting the answer choices either. Like, it just didn't make sense for the scenario. But you had to remember B. fragilis is one of the normal dominant guys in the colon. If you didn't, you wouldn't really think of why would you pick that as an answer choice. This is a question from Amboss right here about, I think it should be osteomyelitis related since it's here. So it's a 3-year-old boy. 3-year-old boy brought to the physician because of 3-day history of fever and chills. The mother reports that he has been limping for 2 days. No history of trauma to this region. Temperature is 102. Physical exam shows dull tenderness over his left leg. The range of motion of the leg is also limited by pain. While walking, he avoids putting weight on his left leg. Lab studies show an erythrocyte sedimentation rate of 67. Right, so that part right there. Elevated ESR is pretty much a giveaway that this is osteomyelitis. An MRI is most likely to show abnormalities in which of the following regions? And the answer was proximal metaphysis of the femur. Now, the other answer choices weren't like distal metaphysis, blah, blah, no, nothing like that. There was only one answer choice that had to do with the metaphysis of the femur, just like it's shown here in the metaphysis of the femur. But the other answer choices were just like different parts, like your arm, your back, etc. So fever, chills, limping, local tenderness, and the elevated ESR in this young boy raised concerns for osteomyelitis. Acute osteomyelitis in children is usually caused by hematogenous spread. A particular region of the bone is especially susceptible to the deposition of bacteria, and that particular region is your metaphysis of the femur. Hematogenous osteomyelitis is most common in children and adolescents. The metaphyseal blood supply of the bone is unique in that the nutrient artery supplying the metaphysis makes a sharp loop before it empties into the sinusoidal spaces, where the rate of blood flow is decreased. This creates a medium for bacteria to proliferate. The focus of infection in the metaphysis leads to cellulitis in the bone marrow, inflammation in the bone marrow, causes increased intramedullary pressure, which forces the exudate into the cortex of the bone, where it can rupture through the periosteum. And that's what you're seeing in an MRI. More than 80% of cases of hematogenous osteomyelitis occur in long bones, the femur and the tibia being most common, and cases usually originate in the metaphysis because of the looping that blood vessel makes. My experience with AMBOSS, I didn't go through all of it. I did a lot of AMBOSS with another student I was working with, so that's where I was able to get the AMBOSS questions and put them into the book. I would say, AMBOSS it's not better than UWorld. UWorld is the mainstay. You have to keep with UWorld. But AMBOSS is a good way to test yourself on UWorld. So after you finish UWorld, you can do all of AMBOSS and see where you stand. Did you get better at answering questions? Did you figure out how to tackle questions? Did you figure out how to see what's wrong with the patient and stuff like that? It's a lot better than repeating UWorld because it can burn you out to repeat UWorld. It's kind of boring doing the same thing over and over. So that's where I would put AMBOSS. It's definitely worth doing. It's worth doing. It also has difficult questions, but it also has very good, reasonable questions. And every question always teaches. So AMBOSS does a great job at teaching. I loved AMBOSS because of the x-rays they had. All their x-rays and all their images in general, they do a really good job highlighting what you're supposed to be able to see. Right? So AMBOSS was a very good teaching tool. There's definitely a lot to learn if you do AMBOSS. Just like UWorld. It's just you can't replace it. One of them is not a replacement for the other. You have to do UWorld, and then you can do AMBOSS as well. The next topic here are your urinary tract infections, right? And these are a pretty big deal as well. There's a lot to know. There's a lot to remember. All the differentials and stuff. And then your torches infections, which we talked about over the last few days, right? All the images from Sketchy Micro where there was a torch in the picture. And, of course, any rashes, right? When I was doing my pediatrics rotation, rashes were a pretty big deal. Children came in with rashes all the time. That's usually why the parent brings them in the first place. And just based off of the rash, with enough experience as a physician, you'll know exactly what caused it, right? But, of course, that comes with experience, and experience takes time. And you can make up for some of that time by actually studying enough and looking up a lot of pictures on the internet. But nothing beats actual physical experience of seeing a patient with the rash. So it's a whole different thing when you do that. And then STIs, all the STIs, remembering which one is painful, which one is not painful, right? The breakdown, and PID. So I'm going to finish all of that up and finally finish all that tomorrow. I'm going to stop here for now. So we'll continue up with urinary tract infections in the next episode. Thanks a lot for joining, guys, and good luck. Keep studying.